Start recording also.
Ready? 7:30.
Yes, ma'am.
Anuradha madam, what happened?
Ma'am, it's live, ma'am. You can talk. You can start.
Good evening, everyone. So today I'm presenting a case. I'm Dr.Poorva Dige. I'm second year DNB from Sankara Hospital, Shimoga. A 33-year-old female patient presented to a OPD who is a farmer in profession, resident of Honori. She had a complaint of diminution of vision in both eyes since 3 years. She gives history of gradual, progressive, and painless diminution of vision for distance and near in both eyes since 3 years. She consulted local ophthalmologist and was prescribed glasses. She says vision improved, but it is decreasing even with glasses since the last 1 year. There is no history of frequent eye rubbing, no history of contact lens use. But she gives difficulty in hearing since the last 5 years. No other significant systemic history. She is born of a second-degree consanguineous marriage, and she has one elder brother. She's also married. She also has her own second-degree consanguineous marriage and has a daughter who is in 10th standard now. No similar complaints in any other family members. General examination, she is moderately built, well-oriented to time, place, and person, and no significant finding in general examination. Her head posture is normal. Ocular alignment is orthotropic. Facial symmetry is well maintained, and extraocular movements are full and free in all gazes. Her uncorrected visual acuity in right eye is 6/36 for distance and N18 blur for near. And in left eye, it is 6/18 for distance and N10 blur for near. She is not improving with pinholes and not accepting any glass power.
Dr.Poorva?
Yes, ma'am.
What is the glass power? Is there any AR reading taken?
Yes, ma'am. AR reading was taken and on retinoscopy was also done. On retinoscopy, right eye we had she had a sphere of minus 5.5 diopters and a cylinder of minus 6.5 at 160 degrees axis. And in left eye,
so that is after correcting for the working distance or without?
After correcting.
Okay, retinoscopy is here. Okay.
Yes,
go ahead. Okay.
For left eye, it is minus 5 diopter sphere and cylinder is minus 5.75 at 140 degrees. But even after giving her correction, patient said that there is no visual improvement. And on retinoscopy, scissor reflex was present.
Okay.
So we did her keratometry. Keratometry of both eyes were within normal limits. Then an anterior segment examination. Right eye, eyelids and adnexa were normal. Rhoplast is negative. Cornea is clear. Anterior chamber is well formed and is optically clear. Iris is normal in color and pattern. Pupil was 3 mm round, reacting to direct and indirect light reflex. IOP as measured by NCT was 16 mm or 17 mm of Hg.
So IOP by with what? Is it GAT or NCT?
By NCT.
Okay, you have to mention.
Yes, ma'am. By NCT, IOP measured was 17 mm of Hg.
At what time?
In morning, we had measured at 10 a.m.
Okay.
On slit lamp examination, the lens showed a bulging in the central part on the anterior surface, corresponding to an anterior lenticonus. And on retroillumination, oil droplets sign was seen.
So what about the clarity? You have not mentioned whether it is clear or cataractous.
Lens is clear, ma'am.
That you have to mention, no?
Yes, ma'am.
Okay.
Left eye, eyelids and adnexa are normal. Rho plus is negative. Cornea is clear. Anterior chamber is well formed and optically clear. Iris is normal color and pattern. Pupil is 3 mm, round, central, well reacting to light, direct and indirect light reflex. IOP as measured by non-contact tonometry at morning 10 a.m. is 13 mm of Hg. Lens examination, lens shows anterior subcapsular opacities.
Okay. So there is no lenticonus in left eye.
Lenticonus is not that appreciated as in the right eye. Anteriorly, there is opacity.
Okay.
So on fundus examination, in right eye, the media is clear. Optic disc is round, normal in size, pink in color, with healthy neuroretinal rim, and cup disc ratio is 0.3. Blood vessels are normal, AV ratio is 2:3. The is dull, and fovea had pigmentary alterations.
So you see only black pigments or any yellow dot?
Ma'am, alternate hypopigmented and hyperpigmented patches were seen.
Hypopigmented means white dots are also there.
Yes, ma'am.
Okay.
Then in left eye, media is clear. Optic disc is round, normal in size, pink in color. Neuroretinal rim is healthy. Cup disc ratio is 0.3. Blood vessels are normal. AV ratio is 2:3. FR is dull, and similar pigmentary alterations were present at the fovea. So my provisional diagnosis is right eye anterior lenticonus, left eye anterior subcortical opacities, and also patient has mild hearing loss. So she's suspected to have Alport syndrome.
Okay.
So we further investigated the
So
patient.
what else you could have asked? Now you have come to the diagnosis that it is Alpert's, and
Yes.
you know that it is Alpert's. What other history you could have asked? What is the usual presenting, means non-ophthalmic?
Hearing loss is one, ma'am.
So that you have already mentioned.
Any hematuria history we can ask.
Yes. Any high colored urine history is there because they present with chronic hematuria. That is the early manifestation, I think.
Yes, ma'am. That history she was not giving actually.
Okay.
And
Okay,
one more thing, go to the general examination. Is there anything which we could do extra for this case? Any idea? Do you, for all cases, do you measure the blood pressure? Do we have the habit of measuring the blood pressure for all cases?
Yes, so we should measure blood pressure.
That maybe if not for all cases, at least for in this case,
Yes, sir.
maybe once you get to know about the diagnosis after coming to that, maybe retrograde, you can go and at least verify the blood pressure because of the importance of the other systemic issues involved in this case. Probably
Yes.
that is one thing which you can look upon into. And
Yes.
there's the other things like, is there any anemia or the patient is having any anemia?
Yes, so we later did her investigations.
Anemia, you can look into the face. Yeah, we have done that later.
In
Okay.
general examination also, you can
General examination also, you
tongue
can see
paler,
whether
nose
the
paler, those things.
yeah. And basically, we will not as an
Conjunctiva,
off
pale
yeah
conjunctiva.
yeah as an ophthalmological point of view. In all cases, we will not be looking into the pale conjunctiva, pale tongue, and other things. But once you come to know that it is something which is involving the renal issues, and then then these two things becomes more important, like checking the BP and pulse rate, whether there is any pale,
Tachycardia.
tachycardia, because of
And
the anemia and things. These
exertional
two,
dyspnea.
yeah, because eventually many a times we forget that eye is a part of the human body. And then eventually when you want to go for a intervention, like some kind of a surgery and other things, if we have not looked into the other parameters like hypertension, anemia, and things like that, we end up with issues. Okay. Yeah. Anyway, go ahead.
So we did OCT of both eyes. In right eye, as we can see, the foveal contour was altered. There is inner retinal layer loss and also focal EZ loss is present. And lamellar defects could be seen.
Okay. Can we call that as a staircase macula something? Okay, go ahead.
In left eye, the foveal contour was maintained and there was temporal retinal thinning seen.
So in retina, what is expected in Alport syndrome?
In Alport syndrome, patients can have macular hole, which are usually larger than the commonly seen tractional macular holes. And temporal retinal thinning is also been seen in many studies. And commonly dot and fleck on fundus examination, dot and fleck retinopathy is also seen.
Okay.
It's
And
better you have to come the other way, actually. The first is the thing which you have to say is the one which you told the last one. Okay. The initial lesions, asymptomatic also, they can have that white and dot fleck like things even when there is no, yeah, when there is no visual impairment. Even in that stage, it can be there. And then comes the foveal thinning, and then comes the temporal more prominent temporal thinning, and then the whole is the last thing to be mentioned. So examiners are always waiting to pull your leg. That if you tell the least common thing, then you get hold in that. So it's better you tell in a graded fashion, which is the early sign, which is the established signs, which is the advanced sequelae. You come in that way. Okay, whichever finding we are saying when you are explaining. Okay.
Yes.
Anyway.
Then this is a right eye Scheimpflug image, which shows anterior bulge in the central part of the lens. This is the left eye image. Then we carried out blood investigations. In blood investigations, the serum creat came to be about 1.8 milligram per day. And on urine routine microscopy, albuminuria was present.
So
we
there is a
referred
mild hypertension. 130 to 90 means mild. Patient is 36 years old, no?
Yes, 33-year-old.
Okay. Okay, go ahead.
So we referred the patient to nephrologist for further evaluation. We are still awaiting for his nephrologist opinion. It will be done in the next week. And she is advised ophthalmology review every 6 monthly. And also she's explained about the genetic importance of genetic analysis and genetic counseling should be done.
In this case, according to the genetics, what do you think is slightly different? According to my understanding, I think it's mostly in the middle-aged males, right? It's a common presentation.
Yes,
Here it is a female of 33 years old, right?
yes.
Yeah. And
Actually, common.
Males also it manifests early, and that end stage renal disease, they die at an earlier age than females. Only
than
for
females.
females, at middle age it manifests. So it is even earlier in males because it is autosomal recessive. Sorry, sex-linked
Sex-linked recessive.
Sorry. Not recessive, it is sex-linked.
Yes.
But here And all three types, autosomal dominant is there and recessive also is there,
This
and
is also there.
X-linked also is there. So what is the gene involved, Poorva?
Ma'am, the COL4A gene is involved. It
So
codes for
that is the gene coding type 4 collagen.
yes, ma'am.
Okay, there are mutations.
Yes, ma'am. It usually the alpha 4, 5, and 6 chains will be involved in this.
Okay. So 3, 4, 5 genes, alpha 3, 4, 5. Yes.
Yes, ma'am.
Okay. So what is the basic pathology here?
Ma'am, these alpha proteins will form the basement membrane,
Okay.
which are usually present in the glomerulus, in eye, and in the cochlea. So
So that
when
is the glomerular basement membrane,
yes,
isn't
ma'am.
it?
Yes,
Okay.
ma'am.
And what
So
are the structure?
in the
It will-
cochlea, in the organ of Corti, it will be present as a basement membrane, and in eye, it will be present in cornea. It will be present in the Bowman's membrane, Descemet's membrane, and
Okay.
in anterior anterior lens capsule, and in the retina, it will be present in ILM
Yeah.
and the
Yeah.
Brooks
Thinning of
membrane.
ILM, Brooks membrane. Okay. In cornea, what else can be expected?
There can be recurrent corneal erosions as the
Okay.
basement membrane will be involved. And rarely, some patients can have posterior polymorphous corneal dystrophy.
So, okay. Is there any history of early morning pain, redness, watering, something like that? Is there
No,
any
ma'am.
history in this
She is
case?
not giving any such history.
Okay. 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 Go ahead.
So a take-home message from this case is that patients with systemic conditions can present with ophthalmological findings. A good ophthalmologic examination aids in the diagnosis and management of underlying systemic disease. So,
Okay. So how are you going to manage this? She is not accepting glasses and not improving with glasses, right?
yes, ma'am.
And
Uh,
the right eye vision is only 636, I think. Left eye 618. Right eye, you said it is clear. Lens is clear. Only lenticonus is there.
yes, ma'am.
So,
Ma'am, actually, in her fundus also there is EZ loss and retinal thinning.
okay.
So that
Yes.
can also contribute to less vision.
Okay.
But
Okay.
for
Very good.
lenticonus, we can do IOL exchange for better vision.
Okay. Clear lens extraction, you can plan.
Yes, ma'am.
Okay. So what could be the difficulties in cataract surgery? Could there be any difficulties? Will there be any difficulties during cataract surgery?
During rexis,
Hmm. So that
it-
central part is very thin, no? We
yes,
usually start rexus at the center.
yes,
So
ma'am.
it can go wrong, this type of cases. Okay.
Yes,
So
yes.
what methods you can employ to have a good rexus in this case?
Maybe we can start with a smaller rexis.
Still, that central part is very thin, and sometimes there can be rupture also, anti-capsule rupture also.
By
So
capsulotomy, if we do instead of
yeah, instead of needle, we can try something else. Which method is better? Forceps method is better, or needle method? What is it called? Cystitome method is better.
in this case, I think, ma'am, we can try forceps.
Okay, okay, go ahead.
So certain systemic conditions associated with lens malfunctions. Alport syndrome, as we saw, is the primary pathology lies in the mutation of collagen 4A345 gene, and abnormality lies in the basement membrane. So the ophthalmological features in IL ports are recurrent corneal erosions, posterior polymorphous corneal dystrophy, anterior lenticonus, cataract, macular hole. Similarly, in Loeys syndrome, we get posterior lenticonus. There can be congenital cataract and lens-induced glaucoma. Corneal keloid can also be seen. Weil-Marchesani syndrome can present with microspheropakia, ectopia lentis, and lens-induced glaucoma. In Marfan syndrome, there is ectopia lentis, which is commonly in the superior temporal dislocation of lens. It leading to myopia, and scleral thinning retinal detachments can be seen. Homocystinuria can show bilateral lens subluxation, commonly in the inferonasal quadrant, and myopia. So certain patients can present with lens coloboma. So lens coloboma can either be an isolated anomaly or it can be associated with other syndromes like Treacher-Collins-Patau syndrome, Chart syndrome. So eyes are a window to the human body. So from ophthalmologic examination, we can diagnose many systemic disorders. And genetic testing and counseling plays an important role in managing these patients. So multidisciplinary approach is necessary for proper management of such cases.
Okay. So, what other systemic manifestations we can do some clinical diagnosis examining the eyes? Do you have any other than what you have presented? What are the common things which we see?
Like hypertension, diabetes, these conditions can also present with retinal
They
change.
always go layer by layer. Okay, sometimes you see the lids. Okay, so xanthelisma. Okay, start from the lids. Like xanthelisma, you're seeing. Okay, then in that case you can go for lipid evaluations in a young age group, and then you're seeing Arcus in a less than 40-year or juvenile Arcus juvenalis. In that case, you can evaluate in that line. Third, sometimes you see a lot of pigment changes or drug depositions in the cornea, which are all indications of people on antipsychotic drugs.
Antipsychotic drugs.
Okay,
Yes.
so that is
So
third.
what
Then
antipsychotic? Which
Uh,
antipsychotic?
Chlorphenol,
Chlorpromazine.
chlorpromazine can cause.
That typically produces anterior capsular.
yeah.
So
Yes.
your left eye here in this case, is it anterior capsular or subcapsular?
Subcapsular.
Subcapsular. Okay. Any other drug which can cause anterior capsular besides chlorpromazine? Okay. Gold also can cause anterior capsular. Okay.
What is one diagnostic thing which usually is referred from physicians or endocrinologists or somebody for to look into the cornea for a systemic diagnosis?
For Wilson's disease,
Hmm.
for Fisher's ring,
Okay.
Clough ring.
Okay. And then anything else? Like lens you have told. And
Thyroid
more,
can
yeah, thyroid.
then present
Very
with.
common. Very commonly. Very
Yes.
commonly seen. Thyroid and more very commonly missed out feature, one systemic feature which we mostly miss out is acromegaly. So many cases acromegaly. We sometimes the facial features and other things are easily missed, and they will be having diabetes and non-controlled diabetes and other things. Even sometimes other physicians do miss it and they come for cataract and other things, and we see acromegaly, very common. We've seen so many cases. they have a stout tongue and other things. When you go and operate, then you have, they are not very comfortable lying down because of the tongue, and they're very uncooperative. So we should always identify those cases and send to them, get it treated, and keep an nasal oxygen and other things. Tell them to open their mouth and breathe, and then proceed with surgery. Many a times we have gone through that. So commonly missed systemic findings. These are all. Anemia is very commonly missed. Anemia, okay, pale conjunctiva and pale tongue and disc pallor. Okay. And the other thing is temporal pallor. Very commonly missed is anemia, disc pallor, temporal pallor. Okay. And anything else?
So what other systemic diseases affect lens, produce cataract?
Diabetes.
Okay,
And
what type of cataract?
Sun.
What type? Snowflake.
Snowflake cataract.
So which diabetics? Type 1 or type 2?
Usually type 1 diabetes.
Okay, juvenile. What is the underlying pathology?
The duration of diabetes.
No. Why cataract develops? How cataract develops?
It is based on the pump mechanism on the lens fibers. So there is
Pump mechanism.
pump mechanism.
In hyperglycemia, what happens?
There is swelling up of the lens fibers.
So what accumulates inside the lens?
Sorbitol pathway is affected.
Okay, so that is the old theory. Some latest theory also is there. Any idea? Okay. So what are the diseases? One is and in type 2, what type of cataract develops?
Usually posterior subcapsular cataract.
No. What is the difference between a diabetic cataract and age-related cataract? Is there any difference? The most commonly it is nuclear cataract. Is there any difference regarding age of onset?
Diabetics will have an early onset.
Okay, good. And what about the maturity? Is there any difference in the maturity of an age-related cataract and the diabetic cataract? It matures fast, no? Rapidly progresses the diabetic cataract. The onset is earlier, at the same time, progress also is fast, especially when the condition is not under control. Okay. What other systemic diseases can produce cataract?
Steroid intake for a long time.
Very good. So what are the various scenarios where steroid intake is higher?
Patients on immunological disorders will take steroids for a long period of time. Then asthmatic patients. And dermatological conditions, if patients are having then topical steroids and all.
So atopic dermatitis and all. Okay.
Yes.
So what else? Any other systemic disease which can produce cataract? So what is presenile cataract? This patient is only 36 years old, no?
Yes, ma'am.
So we can call it as a presenile cataract?
Yes,
so what are the causes of presenile cataract?
Presenile cataract can be due to diabetes, steroid intake, or due to complicated cataract like in uveitic patients.
So that is different, no? The moment you say complicated, the causes are different. So what are all the causes of complicated cataract?
Complicated cataract can occur after in patients with uveitis.
So this is how you should be careful in examinations. You one slip of tongue, the examiner deviates. Okay. Okay.
Uveitis post-trauma.
Post-trauma is again it is traumatic cataract. So what are the causes of complicated cataract? One is inflammation. The other
Yes,
is degeneration. So inflammation, it can be anything, right from the corneal ulcer, uveitis, choroiditis, retinitis. And degenerations, what are the degenerations? Most common. What glasses are you wearing?
Mm.
You're wearing glasses, no?
Yes, ma'am.
What refract error you have?
Myopia, simple myopia.
So, what is the cause? Complicated cataract. High myopia can produce no.
Myopia.
Yes, ma'am.
Okay. Okay. Anything else? Young patient, male patient with frontal baldness, then expressionless face, posterior subcapsular cataract. What is it? That is a systemic condition, and that is a presenile cataract also. Any other person? So you are which year? You are primary and which year? Final year?
Second year. Second year.
Second year. Okay, very good. So it is myotonia dystrophica. Okay, one other systemic disease which can produce cataract. And any other systemic disease? So diabetes is over.
G6PD deficiency.
G6PD deficiency, that is a congenital cataract, no?
Yes, ma'am.
This age group.
And okay, in this case, you have mentioned that there is an oil droplet appearance, right?
Yes, ma'am.
Where else do you see oil droplet appearance?
Ma'am, in keratoconus, we can see oil droplet.
No, just now you have mentioned. G6PD deficiency, where do you see?
Galactosemia.
Okay, that is one other case, no? Cataract, typical oil droplet appearance will be there. And in myotonia dystrophia, what type of cataract do you see?
Polychromatic.
No. Polychromatic cluster. The moment you utter polychromatic cluster means it is a complicated cataract. Right? Then here, what do you see? That cluster will be there. But
Christmas
the
tree.
terminology is different.
Christmas tree appearance.
Yes, Christmas tree appearance and that iridescent crystal-like cataract will be there initially. Okay.
Yes.
Any other systemic disease? Syndromatotic is over, diabetes is over, myotonia dystrophica is over, and anything else?
Atopic dermatitis. Atopic dermatitis.
That's over, no? What type of cataract do you see in atopic?
Anterior subcapsular cataract.
No. There is a typical name. It presents typically. No shield for your defense.
Shield cataract.
Okay. So neurofibromatosis 2 also can produce cataract. Okay. Then I wanted to ask something else. This case, astigmatism is -5 something, right?
Yes, ma'am.
Okay. Can we go for toric in this case? Yes or no? Okay. What is the type of astigmatism here?
Astigmatism.
What are the causes of astigmatism?
Corneal astigmatism or lenticular astigmatism?
Very good. Here, what is it?
Here it is lenticular astigmatism.
So can we go for toric?
Yes, ma'am, we can go.
Really? Ask your sir.
So once you are going to remove you're told that it is a lenticular astigmatism, and you are going to remove the lens after that you're going to put the eye oil. Once you are going to remove the lens, why do you want to put a toric? So
the moment you remove the lens, astigmatism is gone, no? How do you differentiate? How do you differentiate corneal from lenticular astigmatism?
So, how do you order a toric lens?
Based on
How
the
do you-
corneal astigmatism, we will.
Yeah. So, so do you order the toric lens based on the auto refraction or the subjective refraction, or do you order a toric lens or decide whether you're going to operate a toric lens based on the biometry and seeing the corneal keratometry values? So, in that case, I think I don't remember you mentioned about the K values. Have you mentioned it?
K values were mentioned, sir.
Yeah,
Mentioned
it
it
is
is
mentioned. Yeah.
45 and
So
46, and their astigmatism is
45.25 and
very less.
46. Oh,
1.5
yeah.
something.
Yeah.
But the AR shows minus 0.5. So you
Yeah.
subtract corneal from the AR. Then you get the
Yeah.
lenticular.
Okay. So I don't think we would require a toric in this case. Okay. Because
Yes.
it's predominantly uh, lenticular reason for an irregular astigmatism, and in this case it may not be correct also. The values may not be really correct also, because so in that case we don't need to go for a toric. And I think based on the K values, like somewhere close to 1.25 difference is there in the right eye, and also almost in the left eye. Okay, but eventually I don't think we'll require a toric in this case. One. Okay. So what next? You, you can continue with your presentation. You finished your presentation.
Yeah.
So finally, what are the two facial features which you would see which are significant for systemic evaluation from our sides? Have we left about Sturge-Weber syndrome and systemic neurofibromatosis? Two other things. Okay, sometimes apart from the cataract, but we are discussing more on the cataract part. These two are also important. It's very difficult sometimes in our facial color. It is difficult for a subtle difference in the colors. We can miss out the Sturge Weber's commonly. Okay.
So if it is a congenital cataract, what systemic diseases can produce?
For congenital cataract, in first torch infections like rubella and
So those are okay. Inflammation. Okay.
infective conditions. Then
Anything else? Any chromosomal?
G6PD deficiency,
That is metabolic.
metabolic.
Galactosemia, Fabry's, mannosidosis, all those things. Systemic with characteristic features, short stature, mental retardation, or sweet character.
Down syndrome.
Yes, Down syndrome and Edwards. Okay.
Yes.
So suppose in this case your axis is extending to the periphery. How do you manage? Because it is very thin and bulged out.
So you can do capsulotomy and then continue with phyresis.
What?
If it is extending, then we can do capsulotomy and then continue with that.
Your axis is extending to the periphery, ma. How will you manage? Okay, too much for your second year only, no? Okay. So any advanced method of doing capsular axis? This is not related to the previous one. So we need not do.
Flax.
Yes. What is flax?
Laser assisted cataract surgery.
Which laser? Which laser?
Femtosecond.
Femtosecond. Okay. What type of laser it is? Okay. Okay. So you can use your visco, no? What type of visco?
In this patient, no?
If it extends to the periphery, what are the
Then,
types of viscos?
Cohesive and dispersive.
No, which type you prefer?
For this, we can use cohesive.
Cohesive. Okay. What are the names? What are the characteristics? What are the names?
Cohesive is Helon, and
what is the pharmacological name in the examination? You are supposed to say the pharmacological name, not the trade names, right?
Yes.
What is it? What do you mix in the block to give block?
Hyaluronidase.
Now tell me the name, pharmacological name. Okay. Sodium
hyaluronidase.
Okay.
Hyaluronate.
Okay. Okay. So it is 2012. So we have to continue for 8:30 or?
Madam, if presentation and interaction is over, then we can wind it up.
We can wind it up. Okay.
Yes, ma'am.
So I just
Any questions in the chat box, Kevin?
Chat box.
No, ma'am. No question.
Okay.
7.
Vijayaraghavan, sir, anything from your end?
No, madam. She is almost done. Yeah. Covered everything fully.
Dr.Poorva, anything you would like to leave at the end?
Okay. Dr.Poorva.
Yes, ma'am.
You have made an Apurva presentation.
Dr.Poorva, anything from your side to say?
No, ma'am.
Okay.
Thank you, ma'am. Thank you, sir. Thank you, ma'am.
Okay.
Thank you.
Okay. Kevin, close it.
Okay, I can leave, no, Radhika?
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you, Vijayaraghavan, sir.
Thank you, madam.
Okay, sir. Thank you. Thank you, Dr.Poorva.
Thank you, ma'am.